Good morning, friends and colleagues. I'm Anthony, a hand surgeon based at Raffles Hospital. I would first like to thank Dr. Janice Liao for the invitation to share with you this morning about a relatively complicated topic in hand surgery. So, as a trainee, I've always found the concepts of carpal instability a little bit difficult to understand. And this is made even more difficult by the numerous classifications and the complex chapters in various textbooks. So hopefully this morning, as we go through the talk, we can break it down into simpler components. And at the end of the talk, if we can explain carpal instability in 3 simple sentences, I would consider that a pretty good day. So let's start by looking at what constitutes carpal instability. So some patients may experience wrist pain on loading. Some may experience instability on load, usually expressed as a lack of confidence to bear weight. And other patients would experience both pain and instability on loading. So why do patients feel that? So it all starts with having a little bit of structural defect. It can be due to ligament insufficiency or bony abnormality. And of course, this is a wide spectrum from mild ligament injuries through to chronic attritional injuries of ligaments leading to gross instability. So when the ligament and bony anatomies of the wrist is affected, the usually coordinated movements between the bones, especially at the scaphoid and lunate, becomes uncoordinated. So this would initially leads to synovitis or inflammation of the wrist joint. And over time, through multiple healing or inflammatory processes and cycles, cysts may actually form around the site of unhealed ligaments. And if left unchecked, this disrupted kinematics of the wrist would actually lead to cartilage wear and tear around the joint and eventually culminating in end-stage arthritis. So let's focus a little bit of our attention on the most common carpal instability, that is the scapholunate junction. So the key concept is this. The lunate is the center of the wrist, and the most mobile joint is the scapholunate joint, because the scaphoid actually moves to accommodate movement of the distal carpal row. So for instance, when it's in neutral, the scaphoid is somewhat extended. In radial deviation, the trapezium and trapezoid squats onto the scaphoid. So this actually causes scaphoid to flex. And then in scaphoid flexion, one can see the scaphoid ring sign. So basically, a scaphoid ring sign is a superimposed distal pole of the scaphoid onto its radiological footprint, giving rise to this like ring sign, as you can see in the dashed black lines here. So in ulnar deviation, the trapezium and trapezoid pulls on the scaphoid to go into full extension. So this is a key concept that one needs to understand pertaining to scapholunate instability. Now this is a fluoroscopy of a wrist joint. So for instance, in a picture, the video on the left, you can see that the scaphoid actually moves in a well-coordinated manner, whereas in the picture video on the right, as the wrist goes in radial ulnar deviation, you can see the scaphoid and lunate gapping open, and the scaphoid seems to lag behind the lunate in its from radial to ulnar deviation. So with an abnormal movement like this, patients with going through repetitive activities would experience inflammation and pain around the wrist, and also the lack of confidence or ability to weight bear on the affected wrist. Oops. Okay. Let's move to the next slide. So the clinical evaluation of a scapholunate instability starts pretty much with a history like everything else. So more common feature of a history is dorsal central wrist pain on loading. So this is most common in the push-up position, for instance, like doing a real push-up, or for instance just pushing on a door or pushing themselves off a chair or table. So things to really clarify with the patient are: 1, does the patient feel pain on pushing alone, or is there other pain affecting the action? And number 2 is to check whether the patient feels awkward or they feel lacking in confidence when pushing. So this is usually a sign that indicates a deeper instability of the wrist. So, and also not forgetting any previous trauma. So the majority of these scapholunate instabilities are actually due to aggravation of old injuries. There are very few acute scapholunate injuries that present in the clinic. So most of the time, patient may have had a fall or a sports injury months to years ago, and then now they start having pain when they do certain activities. And this is important to clarify because most of these injuries are due to the attritional nature of old injuries. So what are the things that we need to look out for on clinical evaluation? Never forget to examine the patient properly. So the first thing to observe around the wrist is symmetry and whether there's a presence of dorsal wrist ganglion. So a ganglion can cause impingement pain, which can also mimic scapholunate instability. So palpate along the 3-4 space. Basically, this is a space just distal to the listus tubercle, where there's a soft spot, and this correlates roughly to the scapholunate interval. I prefer to use arthroscopic landmarks because this really provide me with a very systematic examination of the wrist. So I start at the M3-4, move on to MCR. MCR denotes mid-carpal radial because this is the most common site for ganglion formation and also dorsal radial carpal ligament synovitis. I then move across to MCU, which is just around the LT, lunotricutal interval, to examine for any lunotricutal synovitis. And then I move on to examine the TFCC and the ECU. So after palpating, I would aggravate some of these structures. So for instance, sometimes EPL synovitis, being a third compartment, may mimic a scapholunate instability by having dorsal-central wrist pain. The same can be said for extensor digitorum communis synovitis. And because both EPL and EDCs are involved in positioning of the thumb and fingers, and repetitive strain injuries are very common around these parts from, for example, typing or operating machines and so on. So the next test to do would be the Watson shift, which I will demonstrate in a video after this, and also a push-off test, which is shown in the next slide. The push-off test is a test whereby the patient is instructed to push themselves off a chair or a table while noting for any pain around the area indicated by a star on this diagram. So that is the listus tubercle and scapholunate interval, and pain in this region usually indicates synovitis above the joint. The Watson shift test is very well outlined in the video that will play shortly.
The Watson test is also called the scaphoid lunate shift test because it tests for laxity between these two carpal bones. To perform the test, start with the forearm pronated, vertical and supported. With their palm facing you, grip the palm from the ulnar side and then specifically grip the scaphoid, located on the radial side of the wrist, over and above the most distal wrist crease. The test movement is as follows: from ulnar deviation and slight extension, passively move into radial deviation and slight flexion. A positive test is indicated by a range of findings, including pain, apprehension, excessive movement, or a subluxation may occur, which reduces with a return back into the ulnar deviation. For further explanation of this test and its uses, please watch the Watson's Test Explained video, and please subscribe to the channel for future releases.
So the presenter has actually outlined three very important concepts in interpreting a Watson's test. So pain at the scapholunate interval indicates synovitis, whereas a apprehension actually indicates greater instability than just synovitis. So for instance, if the patient actually shirk or draw themselves away while you're performing the Watson test, that is actually defined as apprehension. Whereas an end-stage chronic scapholunate instability would usually culminate in the scaphoid subluxing around the wrist when the test is performed. The next step in assessing a potential scapholunate instability would be X-rays. So the specific X-rays to obtain would be a neutral PA wrist and a PA wrist with a clenched fist. So if you note on the this series of X-rays on the left, in neutral position, the scapholunate junction appears normal. When patient clenches the fist, the load, the pull of the tendons, transmit the force through the capitate, driving it into the scapholunate interval. And if there were gross laxity, as in this case, the gap would spring open, and a gap would be very apparent between the scaphoid and the lunate. So radiologically, this is also called the Terry-Thomas sign, named after a comedian with a missing front tooth. So on the lateral side view of the X-rays, look out for DC deformities. So what that implies is that the lunate goes into extension relative to the radius, and the capitate goes into flexion relative to the lunate. So when this deformity is apparent on X-ray, it usually indicates a later stage of scapholunate instability, whereby the dorsal supporting structures, mainly the dorsal radial carpal ligament and the dorsal intercarpal ligament, have been attenuated over time. So this indicates a more advanced stage of scapholunate instability, and it also can be classified as slack wrist. Another useful modality for evaluating a painful wrist is the MRI. However, bear in mind that the accuracy of the MRI interpretation is only as good as the clinical examination. What I mean by that is that the findings in MRI has to be correlated and corroborated with findings from the physical examination. Though MRI interpretation is a relatively complex topic on its own, we'll break it down into simple components that I hope we can take home today. So let's start by evaluating the coronal sections of the wrist joint. I would usually start by looking at the morphology and integrity of the dorsal radial carpal and dorsal intercarpal ligament. And then I would scroll a little bit deeper to look at the scapholunate interval. And this is cross-referenced with a cross-section anatomy of that region. So I am looking for an intact scapholunate ligament and whether the presence of any cyst or fluid within the scapholunate interval. So some of the more common findings from a painful dorsal central wrist would be a ganglion that arises from the joint. So in this case, the ganglion has attenuated the dorsal intercarpal ligament while leaving the dorsal radial carpal ligament intact. And you can also see that the dorsal scapholunate ligament is intact as well in this case. So all MRI scans should be referenced in three planes: so coronal, cross-section, and a lateral plane, to get a 3D understanding of where the cyst might be. So in this case, you can see that the cyst is fairly large and is distending the wrist capsule. And I wouldn't be surprised that this causes dorsal pain during wrist extension. Now that you have examined the patient, done the X-rays, done the MRIs, it will be useful to put all this together. So the main differentials for dorsal central wrist pain are tendonitis, impingement pain caused by ganglions, and various degrees of scapholunate instability. So we'll start with the leftmost. So in tendonitis, there is usually pain on provocation of the EPL or the EDC tendons in the absence of a ganglion cyst, and push-off is often negative. So it's a Watson test. So in these cases, I would still do an X-ray to exclude other differential diagnoses such as fractures, inflammatory arthritis or tumor, and even rarer, avascular necrosis of the wrist. So in this case, if it's tendonitis, I would consider splint or medications such as NSAIDs or COX-2 inhibitors as the first line of treatment, while second line treatment would that be of injection targeted to the specific dorsal extensor compartments. In the presence of a ganglion and a positive push-off test, this would be suggestive of dorsal impingement pain. And if the patient is symptomatic, I would offer aspiration of the ganglion with the discussion that there is a good chance it might recur versus a excision of the cyst. So in presence of scaphoidal instability, there is a spectrum to this condition. So ganglion may or may not be present. So bear in mind that ganglion is a manifestation of long-term ligamental instability or insufficiency rather than the cause of ligament insufficiency. So in the case of a mild scaphoidal instability, the Watson test may cause pain and there is pain on push-off. I would consider doing fluoroscopy if the facilities are available. I would definitely consider MRI to understand the anatomy a bit better. This will provide a map of presence of synovitis, the state of the dorsal, radial, and dorsal intercarpal ligaments, and as well as presence of occult ganglion that cannot be detected during physical examination. So in all stages of scaphoidal instability, I would consider therapy as the first line, with the focus on strengthening and proprioception. And in the case of milder presentations, I would consider injection to the scaphoidal area to reduce the synovitis. And for some patients, this is all that they need because they have mild inflammation and therefore pain. And with a steroid, they can actually progress through their therapy to strengthen the wrist, and surgery may be avoided altogether. So in the presence of apprehension during a Watson test or the push-off test, this may indicate a more advanced stage of scaphoidal instability. And I would definitely still consider doing fluoroscopy and MRIs, as well as subjecting the patients to at least 3 months of therapy before discussion for arthroscopic evaluation and thermal shrinkage of the wrist. So when the Watson test use a subluxing scaphoid, and a push-off is just almost impossible without apprehension of pain, this indicates a fairly advanced stage of scaphoidal instability, and I would just look at the X-ray for presence of arthritis rather than doing MRIs for these patients, because the plan at this stage would be really one of the reconstructive procedures for the joint, whether it's arthroscopic or open reconstruction in the form of, let's say, a trilligamental tenodesis. So there we have it, scaphoidal instability in a nutshell. But that would just represent about 90 to 95% of the clinical cases you might see. So the other 5 to 10% of carpal instability conditions would be due to acute traumatic events, such as perilunate dislocations or axial carpal dislocations, chronic post-traumatic conditions such as adaptive instability caused by distal-radius malunion, or that of a scaphoid nonunion advanced collapse. So the other even less common kinds of instabilities are that caused by soft tissue hyperlaxity, inflammatory arthropathies such as rheumatoid psoriatic arthritis, mid-carpal instabilities, and also the hyperlaxity, acute insufficiency, and the CLIP, capital lunate instability pattern type, indicating a dorsal ligamental insufficiency. So these are more esoteric compared to scapholunate instability, but worth a read for those of you who are interested to know a bit more about these conditions. So for advanced learners, these other supplementary reading might augment your knowledge and understanding of carpal instability. So it'd be good to understand the various theories of carpal kinematics, kinematics being how the wrist actually moves, wrist biomechanics, the loading patterns of the wrist. So I did not bore you with all the details of biomechanical studies around the wrist today, because that would dilute the learning of concepts. And for those who are interested to do surgery to this area, there are various surgical approaches, open or arthroscopic, and there are actually various type of approaches here. So thermal shrinkage, capsulodesis of various forms, the 3 or 4 ligament tenodesis reconstruction, and even partial wrist fusions, which itself is a huge Pandora's box of biomechanics. So we've come to the end of the talk, and for me, I would describe carpal instability as a condition whereby it's implied when there is wrist pain with or without instability on weight bearing. And the symptoms are actually caused by structural defects, disrupting the normal coordinated movement between the carpal bones. And primary goal of treatment is to help patient compensate for these insufficiencies through strengthening, proprioceptive training, and of course, only when these conservative measures are not successful, surgical restoration of bone and soft tissue support would be considered. Thank you for your attention.